Welcome everyone. Please introduce yourself in the chat as well as where you're joining in from. And we are about to start. So, good morning, good afternoon, and good evening, depending on where you are joining us from. And welcome to today's webinar on moving beyond parity, understanding, unpacking, and implementing transformative change in global health leadership. My name is Meher Manzoor, and I'm delighted to be your moderator for this important discussion today. I'm a founder and CEO of Beyond Parity, focusing on rethinking gender equality beyond representation and co-designing gender transformative leadership program for emerging women leaders. I'm also a consultant for diversity, equity, and inclusion with Encompass, where I'm a lead instructor for DEI trainings with USAID staff across their global offices as well as different bureaus. And I have a PhD in health policy and management from Tulane. So let's start with one scenario. So as I read out, please type in the chat what first thing comes to your mind. A father and son are in a horrible car crash that kills the father immediately. The son is rushed to the hospital in critical condition. Because he is about to go under the knife, surgeon says, I can't operate. This boy is my son. So who is the surgeon? Please type in the first thing that comes to your mind. Great. I see that a lot of people actually typed mother, which is the right answer. But when this study was conducted by Boston University and was presented to two groups, a lot of people actually did not think that it could be a mother. And I actually tested this scenario out with my husband yesterday, and he was also confused, like saying grandfather, father. And sometimes, so this really showed in a group of two studies that they presented to 297 university students who were psychology students, as well as 103 children aged between 7 to 17. And almost like 15% only got the right answer, which really sometimes present the elements of unconscious bias, the hidden behaviors and thoughts that really influence our perceptions and decisions without us even realizing them. Whereas the conscious bias are those that manifest themselves as intentional responses or thoughts. But these biases actually manifest themselves within our organizations and at work. And influence our hiring decisions, processes, performance evaluations, the ways in which job descriptions are written, interpersonal interactions with our colleagues, as well as decision-making processes, contributing to the perpetuation of gender disparities. For example, within the health sector, we see that women remain underrepresented in leadership roles, whereas 69% of global health organizations are still headed by men. And furthermore, if you go to look at this disparity in low and middle income countries, it is more wide. Um, and the gender pay gap within the health sector is also widest with 26 to 29%. But again, from the middle income and high income countries, we don't know what's happening in the low and middle income countries because enough data isn't there. And so moving beyond parity really requires to tackle these biases and how they influence themselves in systemic and institutional processes head on. And this requires not only policy reforms and legislative changes, but also fostering an inclusive and diverse organizational culture, which is really without bias and discrimination, which means that it's embedded into the value. So today we will be exploring the steps that are needed to address these systemic and institutional barriers to promote gender equality and creating a more inclusive global health leadership. Our agenda is full of insightful discussions, expert perspectives, and actionable strategies. So let's embark on this journey together as we delve into the complexities of moving beyond parity and unpacking some of these buzzwords and charting a course towards more gender equal future. So I will take a moment to now introduce our esteemed panelists. So we have with us Katja Perhemen. She is a former a Finnish diplomat and currently a senior advisor and focal point for women in the UN system. Her work has been expanding international affairs and diplomacy and intergovernmental negotiations, leadership, human rights, and gender equality. Then we have with us Dr. Johanna Ria. She is a research fellow with the United Nations Institute for Global Health, and she's an epidemiologist with over 12 years of experience in global health policy, research, and program monitoring and evaluation at international and country levels. Then we have with us Jim Campbell, who is the Director of Health Workforce at the World Health Organization. Well, he oversees the development and implementation of global public goods, evidence, and tools to generate investments in education, employment, and retention of the healthcare workforce, and the pursuit of global health security and universal health coverage to really achieve sustainable development goals. Then we have with us Myra Betron, who's the Technical Director of Gender at JPIGO and leads the integration of strategies that promote gender equality within JPIGO's program worldwide, including global programs on maternal health, family planning, and HIV prevention. And lastly, we have with us Dr. Zara Zinelli, who's a doctoral candidate in global health leadership and practice at the University of Washington in Seattle. She's a medical doctor and health systems and policy researcher, as well as in her work, she really applies intersectionality lens and the need for moving beyond gender parity. So I welcome you all to this esteemed conversation, an important conversation. So thank you for joining us today. We really begin with asking Katya, as a focal point for women in the UN system, you are responsible for driving forward gender equality as well as gender parity initiatives and fostering enabling environments. So could you kindly share some insights and experiences from your work in doing this important work? And what are some of the challenges of doing that you have encountered in institutional reforms and changes with the large systems such as the UN system? So over to you, Katya.
Wonderful. Thank you so much, Mayor. And let me just say that it's a great pleasure to be part of this impressive, very impressive panel and such an important discussion. Now, as you mentioned, my office at UN Women focuses on enhancing gender parity across the whole UN. This means that numbers are very important for us, as well as regular monitoring and reporting. Now, based on my experience, it's absolutely critical to increase transparency and provide most updated data if we truly want to make a difference and eventually achieve parity and equality. So in 2017, when we started this work, there was no current parity data available. All data was approximately from 2 to 4 years old. And this is why we launched the UN system-wide dashboard on gender parity. And my colleagues perhaps can share a link to this, or I can do it later. It is a publicly available tool that shows the latest available data on the representation of women and men by UN entity, grade level, and duty station. And it really helps hiring managers and others to understand where the gaps are prior to any recruitment process. And this level of transparency has truly helped us and creates what I would call a healthy competition among UN entities. 6 years ago, 5 out of 38 UN entities had reached parity. Now the number is 27. And this is great news, right? However, as we know, the numbers can and will change quickly in case we don't look beyond them as well. And what do I mean by this? I mean that gender parity is not merely about numbers. We need to ask, for instance, whether we provide everyone with equal opportunities through our policies and practices. Are we serious about zero tolerance for discrimination and any form of harassment? How do we tackle our biases and stereotypes that you also refer to, Mayor? How do we change our organizational culture so that we can attract more women and retain the ones that we have? So we as UN Women developed the enabling environment guidelines for the UN system with recommendations on what to do. In such enabling environments, for instance, we see lactation rooms and reasonable accommodations available, family-friendly policies and flexible working arrangements implemented and encouraged for, standards of conduct taken seriously, thereby people feeling safe and respected. Biases and stereotypes are discussed and people feel included and motivated. Sounds logical and easy. Isn't an enabling working environment what everybody wants? Well, we did face a few challenges, especially in the beginning of this transformative change process. For instance, there was internal resistance, whereby some men would ask, what about us? What about our rights and expectations? We also heard about lack of resources and thereby lack of implementation of the guidelines and parity goals. So how did we tackle such challenges and what worked? First of all, the UN Secretary General's message from the top was loud and clear. He wants to achieve parity by 2028, as it benefits everyone, as it benefits the whole organization, and this is a priority. He reiterated this message time and again and approved policy changes to enhance parity. Now, this trickled down to the management levels. So the leadership buy-in has been one of the most important success factors. Also, the role of UN gender focal points has been crucial. We lead and coordinate this network of over 500 focal points across the UN, and their role is to enhance parity and create enabling working environments together with their leadership. We provide them with coordinated and coherent guidance as well as capacity building. And one of the key factors for progress with focal points has been to develop implementation plans on how to achieve parity with clear goals, action, division of labor, very clear timelines, and monitoring. And now most UN entities have such a plan in place. And interestingly, according to our research, those UN entities that have focal points working with their leadership are closer to reaching parity or have already reached their target. And let me underline that we would not be able to do this work by ourselves as UN Women. These focal points who represent different UN entities across the whole system, they have truly contributed to making a difference, also with changing mindsets, monitoring data, and providing facts and advocacy across the whole UN. We have also pooled resources, including in the field locations. And let's be honest, to create an enabling working environment is not so much about money, but of changing our mindsets and the ways we work. We have also paid more attention to security questions and access to health services to be able to attract more women to peacekeeping and field, where we have currently the greatest gaps with a view to reaching parity. Last year, we also launched UN System-Wide Knowledge Hub on addressing sexual harassment. It is publicly available resource and a key tool to foster transparency and enhance knowledge sharing on this prevalent issue. Now, before I conclude, let me emphasize that progress towards parity should complement and reaffirm broader aspects of diversity and inclusion. As we know, women are not a homogeneous group, but they face different barriers based on their identities. To conclude, I'm happy to announce that we have now, as the UN, achieved parity across the professional levels and above categories, with 49.5% of women's representation. If we also include the general service and non-staff categories, women's representation stands at 47%. These are record high numbers for us. And 10 years ago, these numbers looked completely different. So thank you so much, and over to you, Mayor.
Thank you, Katya, for sharing with us all the extensive work that UN is doing in achieving parity. And as you rightly said, making institutional change really drives from policy as well as like embedding it into the culture, as you're mentioning very rightly that you have overcome some of these challenges by appointing the focal points, giving them accountability, also monitoring their progress, and keeping them in the conversations to really implementing diversity equity across different measures of progress as well, which is like moving beyond just parity. So we move over to Johanna Ria, who is the research fellow at UN, and she at UNU, which is the UN University. And in her work, she has really emphasized on prioritizing some of these feminist leadership practices, particularly in the context of holy crisis and competing priorities. And so, could you really elaborate on what you mean by this and tell us where the sites for change are within the organizations? Joanna is unable to join us because of the time difference, but she has shared with us the video that we will play.
Thank you so much, Meher, for inviting me to be part of this panel, the inaugural panel on this issue and topic. And I think it's a really critical one. And thank you for, setting up the series. I think, firstly, in the current context, and as you've touched on already, in the current context of these concurrent crises, whether they be political, whether they be environmental, whether they be, in terms of conflict, war, as well as economic, austerity and cutting back on spending on certain public health issues. It's a really testing time for all of us. And these crises are unlikely to be going away anytime soon. And I think that's a really important point, is that this is probably a permanent state of crises that we're looking at. And one thing that stands out and is very clear is that the current institutions, the current systems are not fit for purpose and are in many ways perpetuating the deep root causes for a lot of these concurrent crises that we're seeing now, whether that be capitalism, whether that be patriarchy. And I think naming and recognizing that is critical. And linked to these issues is very much the control of power, as you've spoken to. Who has power over resources, who controls, who has access to knowledge or information or decision making. And that's where it ties to this leadership question. And as we're seeking to transform, who has power, but also how that power is held accountable, I think it's really important for us to start with our own spheres of influence and our own organizations. And I think in this regard, I really want to draw our attention to a framework that I found very useful, that also, we have a fantastic think piece that's been written by Srilata Batliwala on transformative feminist leadership and details this analytical framework, and is one I want to sort of spend a few minutes expanding on. Further, it's a gender at work analytical framework, and it has 4 quadrants. One set of axes that spans the individual to the more systemic within an organization, and then the other that looks at the informal to formal. And I'll spend a few minutes talking about each of the 4 quadrants and, what the issues are within each of the quadrants and how change might be possible. So the first one being sort of the individual, and, an individual and formal. So that's your role, your particular role within the organization. What resources do you have access to? Where is your voice included in decision-making structures within your organization as an individual? And then the formal, more systemic sort of domain or quadrant has to do with internal organizational hierarchies, the rules that exist, or the policies with regards to handling, discrimination within the organization, for instance. And this is where parity targets would probably sit under the more formal systemic quadrant. And I think these are often the areas, the more formal, whether they be individual or systemic, are the easier to measure, easier to quantify, what is more public and known. And if we move over to the other side of the quadrant, where we're talking about the informal areas, for example, the informal individual quadrant, that really speaks to our own internalized biases, whether we, recognize it explicitly or it's something that comes out unintentionally, but it's biases that we have internalized over our lived experience. It's our privilege that perhaps we don't always recognize. and how we express that privilege with regards to other colleagues, our attitude, our biases, and how we might react to one colleague over another based on internalized discrimination that we believe and we actually reinforce through our actions. And then the last quadrant is the informal systemic. And these are called the deep structures within an organization. And this is more, it's difficult, it's much more difficult to identify. It's sort of, the comments that you'll hear is, this is the way it's done around here. You don't challenge that. It may be sort of unspoken reward or punishment systems, whether you get the silent treatment in the coffee room, or whether a certain group of people goes out to lunch, and it's in those lunch conversations that key decisions are made, or it's decided who gets to work on or convince someone to work on a particular project or progress in their career. And it's these hidden deep structures within an organization that are more difficult to change. And so you have the harder to measure, more difficult to acknowledge and even admit to oneself, whether it's an individual or as an organization, that we have these really harmful deep structures that we need to address. And so often fewer resources are dedicated within an organization to help individuals heal with trauma, for example, their own personal trauma, or to recognize their own forms of bias and how they negatively express their privilege and harm other colleagues. And so this area gets less attention, but actually severely impacts the transformation that's possible within an organization. So although parity could be reached, we have gender parity on all decision-making bodies, if the deep structures continue to exist and a lot of these harmful internalized biases continue to be expressed, very little will change within the organization apart from a set of tick boxes. And so that's where we really need to be pushing ourselves. So I'm conscious of time and I need to wrap up, and maybe I can leave everyone with three takeaway points. One is the need to really focus resources, time, but also thinking about not how to quantify, but how to collectively express and measure progress in this informal side of the framework, right? The second is the need in the formal side. If we're really going to be pushing ourselves beyond parity, let's also think about intersectionality. And are the decision-making bodies truly intersectional with regards to not just gender, but looking at race, looking at class, looking at ability, looking at whether your particular program, health program, for instance, is impacting rural communities. Do you have rural voices on your decision-making bodies? So I think the intersectional perspective is where we can continue to push ourselves and push the needle more and not be satisfied with gender parity. And the third is that we need to change our mindsets beyond a finite, outcome. And we like an end point and an end goal because you feel like you can get there and it's achievable. But actually, I think a lot of the processes and changes we need are ongoing and will never finish because there's always scope for improvement. And I think we need to change the rigidity of some systems to recognize that transformative leadership is going to be a process. And it's not going to be a process with a finite endpoint, but always scope for individuals in decision-making bodies with power to evolve and change and do better.
Thank you so much. So that was Johanna talking us through how deep structures really, are resistant to change, and we need to move towards addressing those if we have to institutionalize change. And she also shared with us the great framework to look at these organizations. So now my question is to you, Jim, because you in your work have really focused on talking about some of these institutional challenges. And you've recently, WHO has published a report, Fair Share of Health and Care Work. So what are some of the key findings from the report, and what are big systematic issues from getting to unpaid care work to paid care work, and how these challenges challenges of institutionalizing, system-wide change, as well as the distribution of work. So please run us through some of your experiences of overcoming these institutional challenges.
Thank you very much, Mayor, and pleasure to join. And good morning, good afternoon, good evening to all those participants I can see from around the world, including somebody from Jakova in Kosovo, where I lived and worked for many years. So indeed, we've just published the report, and due acknowledgement to Dr. Michelle McIsaac, Dr. Jordan Shannon, a huge team of people that were engaged in the analytical work, including one of the panelists here today, Zara, who was part of that group, and then to the peer review personnel to put forward what is a continuing contribution from WHO to the empirical data, the evidence, so that we can start to have the conversations that matter. And Mayor, you just mentioned there about this, one of the key findings that we've got is this description, understanding what is our conversation about when we talk about work in health and care, but understanding that work does not mean worker, or it doesn't mean payments. We've got informal work, we've got unpaid work, we've got undervalued work. And so this spectrum of activities, and what does it mean in reality by some of the numbers? At one end of the spectrum, we have 140 million health and care workers around the world, one of the fastest growing sectors of employment, which is predominantly female, predominantly women around the world. Not in every regional economic area or income classification in every country. We've got some, or every occupation. We have some examples, 2/3 of women around the world, but high income countries, 80+%. Low middle income countries, it comes lower down to 60-65%, and then even lower in some of the geographical regions to about 40-42%. We've got some occupations which are predominantly male. So we really need to go below a single number, but 140 million plus workers, 2/3 of which are women, big numbers. Then we've got about 10 million people in training and education to become health and care workers, and understanding their contributions. That 10 million were actively deployed into the workforce during the COVID pandemic. But these are not workers, they are still students. They are future workers, but they were actively engaged in things. And as we come across the spectrum, then we get into the care work that is not being compensated, that is not being recognized at work. The work often borne by women in families, in communities, in homes, looking after other providers, and they're absolutely essential to the delivery of our population health outcomes, our future emergency preparedness, our engagement around some of those issues. So what we see then from this spectrum, what does the evidence tell us? What some of the key messages? When health systems are weak, right, women end up doing more unpaid work. Right? That correlation proven in the analytical work. So women are acting as the substitute for our healthcare systems around the world. And that's a systemic issue, that's a policy issue, that's a cultural issue, it's an economic issue, as well as what Katya and Johanna have been talking about, organizational issues around gender parity. We have a fundamental problem in the world of work that undervalues women for the same education, the same work, the same hours that they do accordingly come through. And what happens is, as a result, that restricts women's opportunity to have equal participation in labor markets. It restricts their opportunity to even get close to parity in structural issues. And this underinvestment, this under-evaluation is really then problematic. If we don't value it, we're not accurately recognizing the contribution of the sector towards global economies. If we undervalue it again and we don't value the contribution of health and care, there's less investment coming into some of these issues. And then as a result of this empirical, this analytical work, this powerful data to tell the story and create change, the authors in the group have come up with 6 gender value gaps and 31 policy recommendations. And let me acknowledge, UN Women were with us at the launch in New York, and the Commission of the States of Women, the International Labour Organization, with the civil society, academia from around the world, member states, governments, partners coming together. Because those value gaps, the gender value gaps that we see, and the 31 policy reckoning, we need everybody at the table to take action. And then that's one of the key messages. No one institution, no one employer can take action. It's a whole systems approach. Government plus partners, civil society, advocates, men who understand the science, who can read the science and take action accordingly, alongside the women leadership that is necessary. And that's really the direction we want to see. If we want to lift the health and care economy around the world up, we want to address the inequalities around pay, the inequalities in segregation and occupation, the work experience, but we want to recognize the overarching value to society in work and workers and pay accordingly. So let me again, Zara, for your contribution, please do add something that I've missed from the report that speaks to your experience and your work. But to Michelle, Jordan, and all the other contributors, thank you very much. It's a powerful addition to the evidence base, and with evidence, we can have a dialogue, and with dialogue, we can hopefully reach decisions there. Thank you.
Thank you so much, Jim, for sharing us with your findings from the report, but also like pushing the conversation to evidence-based strategies, which is really important to making change. As you've really talked about, like, you know, the undervaluation of women's work as well as the feminization, it really draws our attention to what kind of work we value and what kind of work we don't value, which is really important. So my next question is to Myra Bertrand, who is the technical director at JPIGO. So Myra, you have actively advocated for gender transformative leadership, both in your work as well as making these institutional changes within the technical work and across different countries that JPIGO works with. So what are some of the reflections of doing this kind of work in different kind of environmental settings, cultural contexts, and, you know, diverse cultures? So if you could shed some lights from your experiences.
Thank you so much, Mayor. And it really is an honor to share the stage with my fellow panelists. I've been taking notes furiously, also learning from them. So I have 4 main points that I want to talk about in terms of the lessons of really advocating for and integrating gender transformative leadership, both within our programs at JPIGO as well as within our own JPIGO offices. I think you've got the slide there with those key points that I'll speak to. But the first one, I think, follows on nicely from some of the points Jim was making, which is that we need to really connect this agenda to the work of saving lives and improving health and development outcomes. As an organization, that is very much our mission at JPIGO. And I think that we know, and we've seen, those of us working in this space, the importance of gender equity and gender transformative leadership in terms of its contribution to better health outcomes. But I think we need to tell that story and connect the dots better for people, and to build that evidence base more. So very recently, actually, I facilitated a learning session on gender transformative leadership, and one of the participants came up to me afterwards and said, "This is great, really important to think about, but in my country, where we are dealing with really pressing health issues, we're not really thinking about this. This is a bit more second and third order in terms of Maslow's hierarchy of needs. But, I think that there's plenty of evidence, certainly growing evidence, and more that we need to unpack in terms of how the gender transformative leadership work that we're promoting is important for achieving health outcomes, whether that's the frontline health worker that Jim is speaking about that is underpaid and does not receive training and education opportunities, but is asked to mobilize to reach the most remote communities and underserved, and yet often might be experiencing harassment, abuse, or be mobilizing in very unsafe settings, or whether it is a woman running a hospital but is not respected for the decisions that she's making, or whether it is a midwife that is working in very hierarchical structures and experiencing mistreatment and abuse herself, and therefore passes that on to her clients. I think these are the connections that we need to better make to also recognize the value of this work. I also often hear or am confronted with the question, or should we be in the business of changing cultures? This is perceived at times as a more Western agenda, or perhaps something more relevant for the global North, where we're seen as further along in our gender equality journey. Again, connecting back to what is really most pressing or perceived as most pressing. In fact, at the UN Commission on the Status of Women last week, I heard from some local civil society groups calling out that sometimes they get comments on their proposals from Canadian or American donors saying, are you really, or is what you're proposing in line with your culture? I think oftentimes we as Westerners are the first to feel uncomfortable and question whether we're imposing certain cultures. But at the same time, I think we're naive to think that when we come in with certain frameworks, training packages, checklists to improve health systems, that is not changing a social norm or culture in the way of working. But wouldn't it be great if we did that in a way that was actually also equitable and ensures access for everyone? And I think what we have learned is that in doing this work and training our gender advisors in different country offices, they've said this is very relevant for us, not only in the health systems that we're working in, but within our own offices. And they come up with their own solutions and things that we can learn from. For example, establishing daycare spaces within their offices, or creating special funds so that nursing mothers can travel with their babies when they need to travel for work. And these are things that we should look at doing, not just because there is a progressive or benevolent leader in place, but ensuring that there is a system and policy that is supportive across the board. I think I would also be remiss in not bringing up a key point around the need to make sure that we're not assuming that women and all women leaders are not biased in terms of gender themselves. I think that we know that gender is not, or leadership is not defined by sex, but in fact by gender norms and roles. And many women, as they rise up or enter into leadership, can feel forced to act a certain way into certain models of what leadership looks like. And for them, that, and many of us, what we have seen traditionally more masculine styles of leadership that might manifest in again, being more commanding in terms of wielding power and control. And so we need to engage both men and women in the process for gender transformation. And then the last point I would like to emphasize is that in doing this, we also need to make it personal. So yes, we need to bring out the data about what this means for saving lives and health and development outcomes. But what we found is that we also need to connect with people on a personal level, and to have them reflect on their own lived experiences of inequities. And for that reason, our gender transformative leadership curricula actually is not didactic in the methods that we apply, but in fact uses critical pedagogy or critical consciousness to have individuals reflect on their own experiences, both in group, through case studies, role plays, and other interactive exercises. And through that, we're able to really sort of make that kind of personal switch to understand this is why we need to really invest in this. And I will close there and hand it back to you, Mary.
Thank you so much, Maya, for sharing that. I think that point is very well taken, that we should not assume that certain genders are going to be transformative in nature, but it's just like everybody's business to be really transformative and really reflect them on themselves as well. So with that question, thinking, we now move on to Zara, who has really pushed these conversations towards intersectionality and really like walk us through why this understanding on intersectionality of gender, ethnicity, race, nationalities, and religion and other identities are important in analyzing the distribution of paid and unpaid care work, how we value work, what kind of work we value, what kind of roles we value, and how we can really navigate in terms of operationalizing intersectionality within organizational changes. So over to you, Zana.
Thank you so much for having me, Mer, among this stellar list of panelists. And thank you to my co-panelists for your thought-provoking interventions. I learned a lot. So you've asked me about incorporating an intersectional lens in our approach to health sector's leadership. And I think it's a good moment to sort of look at this intersectional lens towards the end of the panel. We heard a lot, and we know that there's a lot of progress in examining the reasons for women's underrepresentation in health leadership. But a lot of these efforts have fallen short in that they focus mainly on homogeneously sort of increasing women's leadership, women's participation in leadership, where little attention is paid to other social axes that intersect with gender to inhibit progression to higher level positions in health leadership. So this linear single layered approach does not really reflect the complexities of real world experiences that each of us have, including systems and structures of power that we talked about that interact to privilege certain women over others, while excluding many groups of competent women who are minoritized beyond their gender. So an intersectionality approach explicitly focuses on the relationships between these mutually constructed processes, systems, and structures that lead to social differences and inequities, and acknowledges the dynamic interconnectedness of gender with other social identities and locations, especially when looking at women who do not fulfill the often portrayed and represented description of women in leadership, and enables us to avoid further delays in adopting solutions that benefits women from diverse backgrounds and lived experiences. So just like a quick intro to what intersectionality is, it's a concept that was first introduced by Black legal scholar Kimberly Crenshaw. Fortunately, it has emerged as a framework more recently for explaining and addressing inequities, especially in health systems and policy research. And so according to Crenshaw, intersectionality is defined as promoting an understanding of human beings as shaped by the intersection of different social locations that they have, such as their race, ethnicity, indigeneity, gender, class, sexuality, geography, age, disability status, migration status, religion, etc. And so we move beyond looking at these social locations and identities to look at the interactions that occur within a context of connected systems and structures of powers that include laws and policies and state governments and other political and economic unions and media. And so through these processes, interdependent forms of privilege and oppression are shaped. So we see why incorporating this intersectional lens is to our work in the health sector, and especially studying the leadership in the health sector is crucial, and especially important to move beyond gender parity, but also more generally to adopt a decolonial approach to global health governance. So let me give you some examples to paint a clearer picture. The annual report of Global Health 50/50 that came out in 2022 called Boards for All examined publicly available demographic information on 1,946 individuals that hold 2,014 board seats across 146 organizations. Within this cohort, we found that 75% of board seats are held by nationals of high-income countries. Only 2.5% of board seats are held by nationals of low-income countries. Boards of almost half of the organizations in this sample are made up entirely of high-income country nationals. And across these 2014 board seats, only 40% were held by women and less than 1%, so 17 seats specifically out of the 2014 were held by women from low-income countries, only less than 1%. So we can see the intersection of gender and nationality here, for instance, clearly differentiating across access to these positions of power. And so we know that over 70% of the health and social workforce are women, and over 90% of long-term care workforce are women. And we see this reflected in less than 30% of ministers of health, for instance. So we can see this missed opportunity across governance in different levels. So this underrepresentation that we're sort of showing with all these different statistics is clearly not due to a shortage in the pipeline of health workers in that 10 million health workforce students that Jim mentioned. It's because of a multitude of barriers and biases that hinders women's equal participation in leading health systems, and especially women with intersectional identities that are more minoritized. And we know all of this, but we have challenges in terms of operationalizing this intersectional lens. I believe the main reason is that we have not yet adopted an intersectional lens in the research that we do and in the study of the problem. What we've done has been insufficient, and so we can't really fix something that we haven't been able to measure. The problem is that intersectionality is very context specific in this sense, and so we need to elevate more local voices, as Myra mentioned, to be able to understand these contexts more specifically and be able to study them more accurately. Depending on the regional or national context, we see race and ethnicity having a strong intersectional relationship with gender, but there's also the issue of cadre age and financial status. So we know that in many instances, young women are not considered fit for leadership. We know that health worker cadres are clearly divided across the gender line, with cadres that are more predominantly made up of women, such as nurses and midwives, considered less often for positions of leadership. And with regards to the intersection of gender and financial status, we heard a lot about the pay gap, but we also have to consider the parenthood pay gap and the penalties that women who have children bear, because having children is associated with lower wages for women and, surprisingly enough, higher wages for men. So we did a study in Kenya and found out that women often forego higher education or participating in training that can prepare them for leadership positions because they want to prioritize their children financially. So as I'm wrapping up, in conclusion, I want to urge researchers and policymakers to take the first step by committing to move beyond parity and examining the intersecting social identities and social locations of the workforce to understand the nuances of the underrepresentation of women and looking at how leadership looks different from the majority of the workforce. We know that including diverse groups of women at all levels of health systems leadership is important to ensuring that these diverse experiences and perspectives are represented at the decision-making table and would lead to a wider societal transformation and feminist transformation, as Johanna mentioned. I'll wrap up here. Thank you, and over to you, Meher.
Thank you so much. Thank you so much for sharing these daring statistics that show us how intersectionality plays out in decision-making spaces within global health. And to that point, I also like to reiterate that even though, this report also highlighted how almost 80% plus of folks, even from low and middle income countries, are those that were trained in high income countries. So that is also one of the glaring, aspects of intersectionality, that we have, what kind of education we value. And what kind of publications we value, what kind of voices we value, that we, even when we're looking at local voices, they have to be trained in Western countries to be part of these conversations. So now I open the floor for any Q&A. Please feel free to type your chat in the Q&A or unmute yourself if there's an option. Megan, I'm not sure. Yes, so if you raise your hand, Megan can unmute you. So please feel free to ask our panelists any questions that you have for them. And also feel free to use the chat, the Q&A function. I do see one question from Andy. It says, how are LGBTQIA plus folks being incorporated in your work to improve gender parity? I believe this question might be Katya, you in the UN system. And then maybe Jim can also reflect on this within the WHO work.
May I?
Yes.
Great, wonderful. Thank you, Mayor, and thank you for the question. A very relevant question indeed. So our starting point when we developed the enabling environment guidelines that I mentioned was really an intersectional approach, and that included, of course, LGBTQI plus colleagues. And we did have actually more than 200 interviews across the whole UN, and we had the interest group of the LGBTQI plus colleagues involved in when we were discussing and coming up with recommendations. So we have intentionally had this approach. However, I do have to say and mention, then of course, how we report, when I mention representation of women and men, and how do we monitor it? This is a mandate coming from the UN member states. And so far, we are not able to monitor based on our intersectional approach, which we apply in our guidelines. So our hands are sort of tied regarding this particular issue, but again, we are doing our best and really working with different UN entities, civil society representatives, academia, etc., in order to move forward with this area as well. Thank you.
Thank you so much, Katya. And Jim, if you would also like to reflect a little bit on this, and then we have another question from Anna.
Absolutely. So, I mean, WHO's work in its entirety is looking at equal access to health and care, making sure that vulnerable groups, all population groups, geographical race, gender, intersex, etc. Everybody, all people. That's the constitution of WHO. So that's there. When it comes to the workforce, then, if you're looking at this 140 million plus 10 million, give or take, students around the world, 150 million, then clearly, as with any population of interest, there's going to be a share of those that would be within the categories of the boundaries of interest. But I'll be very blunt and very honest. Trying to get beyond disaggregation of age and sex is already a challenge in national data. To be able to then go into further disaggregation, it really is, it's not coming through the national statistical systems. It's not coming through the labor and employment systems. It's not coming through the health systems. So we've really, again, this is what I was saying earlier about we value the partnership with UN Women, with the International Labour Organization, with civil society, with academia, because we've got to dig deeper to get that in. And if you've got data that you know about in your workforce, in your area of interest, if you've got identification from within a nursing group, within a physician group, within a student group, let's get that data surfaced so it's part of it, because it's not there in the government statistics today, and we've got to do better.
Absolutely. Thank you for sharing this important point and challenges of gathering this disaggregated data beyond just sex. So we have another question from Anna. Anna, if you could just unmute yourself and ask.
Yeah, absolutely. And I'd like to build on Andy's question about LGBTQIA, because, you know, in the United States, there's been a really huge backlash to DEI initiatives, which has, you know, largely been synonymous with race, but I think in many institutions is also inclusive of sexual identity. In our own institution, takes on a role for decolonizing global health, which Zara, I know you mentioned. And so maybe the question is about a reflection as we start to see these backlashes within DEI, within institutions, and yet we're talking about creating enabling environments. What's the way forward for institutions when we're grappling with these different kind of issues in the US, but also globally and more broadly? And thank you all so much for joining.
Thank you for asking. Zara and Myra, would you like to answer this question?
Sure. Thank you so much for the question. I think looking at the situation with the strong backlash towards DEI in the US right now, it is quite a bit of a challenge because it is coming from the grassroots, but it's some of the grassroots, but also coming from the top down, and it's not really easy to approach either way. But I think in terms of institutions that are really committed to moving this work forward, there are different models of allyship that I think are at the center of being able to advance our work on DEI. And I think this sort of allyship can also be reflected in the leadership and the distributed leadership. So not just the leadership at the top, but the leadership across the organizations at different levels that can enable, lifting up these voices. I think that's one of the sort of more actionable things that can be done. Over to you, Myra.
Definitely an important question, a tough one. I will say we are in the process of this now as we are trying to develop, or I should say we have a DEI strategy, but really roll out that DEI strategy with our offices globally. And we are definitely having to balance, what is it that we value and really want to say that across the board as an institution, this is what we promote, but at the same time, again, lead with local voices and understand local contexts where, there are laws that might just put people in danger, frankly, right? And so a lot of our curricula, as much as we want to be much more specific and with certain language, we know that can entire conversations down at times. So it is definitely an ongoing balance and learning that we are doing around this.
Thank you so much. Thank you so much for such a great participation and conversations. With that, we conclude our today's discussion, but please stay engaged with us as we explore other exciting conversations in this series on the art of practicing gender transformative leadership. So thank you, Katya. Thank you, Mara. Thank you, Zara. And Jim has left because he was part of these pandemic negotiations. He's back too. But thank you, everyone, for joining us. And please stay tuned.